Good morning, friends. I have the privilege of speaking with you today about the mission that sits behind ethics consultation in our facilities. As many of you know, the Joint Commission requires that our institutions have policies and procedures for addressing ethical issues. And as Kayhan mentioned, Directive 37 of the Ethical and Religious Directives for Catholic Healthcare Services, more commonly referred to as the ERDs, states that an ethics committee or consultation service be available for advisement, educational efforts, and to review and recommend policy. It also highlights the need for familiarity, both with the ERDs and the Catholic tradition's reflection on medicine and ethics. First, I want to say that a deep familiarity with the ERDs is key for certain members of our institutions and absolutely necessary for the maintenance and growth of our identity as Catholic healthcare institutions. This is especially true for those of us who serve on ethics committees and do ethics consultation. There are ample resources out there for gaining such familiarity, including some very good resources from the Catholic Health Association. But let me pose another question for us today, one that gets at the heart of the matter before we find ourselves thinking about ethical issues or the correct interpretation of a particular directive on a particular issue. That question is this: why is ethics consultation so important, central even, to the life of our institutions as members of the Catholic healthcare ministry? I want to suggest three possible answers for your consideration. First, because ethics consultation offers us an opportunity to love our patients and their families. Second, ethics consultation offers us a context in which to hear, that is, to attend to, our patients and their families. And finally, ethics consultation offers us an opportunity to be present with our patients and their families. Love, presence, and communication. Three facets of the mission that sit behind ethics consultation. First, love. Our beloved colleague from the Neiswanger Institute and our dear friend, the Dominican Father Kevin O'Rourke, used to remind audiences that the ERD should be remembered first and foremost for a remarkable claim, one that sets us apart from all other healthcare institutions. It is the presumption, a kind of first principle, that we love our patients. Our work begins in love. As the ERDs point out in the introduction, the mystery of Christ casts light on every facet of Catholic healthcare. It allows us to see Christian love as the animating principle of Catholic healthcare. That's an astounding claim, one that would make many people uncomfortable, as it seems to breach the personal-professional divide that's so dominant in healthcare. But it's worth our paying attention to. Notice how Father O'Rourke personalizes that claim of the ERDs. It's one thing for us to say that love is the animating principle of Catholic healthcare. And it's easy for us to use these nice words. But what does it look like? O'Rourke tells us that it looks like us loving the people who come to us. And that includes those that appear least lovable, the destitute, the dirty, the questionable, the transigent and stubborn, the pitiable. Yes, all those people that Christ healed and loved. We're called to love because we're creatures of inestimable worth in God's eyes. And for this reason, we're called to care deeply about the decisions we make in our institutions that bear upon God's creatures, our patients. Here we must remember that God's love is powerfully democratizing. We are all equal. Our value rests not in our intellectual or physical capacities, neither in our freedom from illness nor our capacity to pay for care, but rather in our belonging to God. These are the lives we're entrusted to care for and value, God's sons and daughters, and we do so in a direct way when we deliberate with reason, wisdom, and love about what the right thing to do is for this particular patient at this particular time, given this particular set of circumstances. And this is the work of ethics consultation, to assist in seeing this truth of our tradition, that life is of inestimable worth, a cherished gift from God, but one that is destined to die. Ours, in part, is the work of trying to find the middle ground, where we rightly love our patients by both vigorously protecting their lives in freely letting them go when their pilgrim journey is complete. In this way, through beginning and ending with the love of our patients as foremost in our minds, ethics consultation can be a work of God's love in the world. Second, presence. A critical but often overlooked component of ethics consultation is the fact that it brings people together in the same room, at the same time. No side conversations at the nursing station, no passing comments to a family member about how things aren't looking good, no ambiguous note in the medical chart. It's important to bring people together. Why? Well, for obvious reasons, it assists in communication. But underneath the obvious rests a point very important to us in Catholic healthcare. We are embodied creatures. We have bodies, and our physical presence to one another matters. The central mystery of the Christian faith is the incarnation, the fact that God becomes one of us. God comes to us through the physical, the taste of wine and bread, the touch of oil, the smell of incense, the light of candles, the sound of the words of a sacramental rite. Our bodies are so central to our self-understanding that even St. Paul notes that we can say little more about heaven than that we must be embodied there too. The body is who we are. We are our bodies, and our bodies are us. And for this reason, presence matters. When we truly see each other, when we can be present to each other in these hard conversations, we have the opportunity to see God in one another. In this way, then, in being with one another and in seeing one another for who we are, ethics consultation can be a work of God's love in the world. And finally, communication. The heart of ethics consultation is communication. It's the art of articulation and the equally important art of hearing. I often cite my colleague, Mark Kuczewski, who notes that 98% of ethics consults are requested on account of a breakdown in communication, and 98% of ethics consults are resolved through restored communication. There is a way in which this makes good sense, but it does call our attention to the fallacy that ethics consultation is really about moral problem solving. It's actually relatively rare that a consult requires the careful parsing of a particular directive or a consideration of the principle of double effect. More common is the need to hear and see someone's pain and suffering and be with them and then talk to them about what's possible and how they might think about their future course, even if that might diverge from what they right now hope for. We are creatures who by our very nature communicate. It is not happenstance that John's Gospel begins by telling us that in the beginning was the Word, and the Word was with God, and the Word was God. Ours is a God that communicates, and we are God's creatures. Our words need to be spoken. God speaks love into the world in the person of Jesus, whose work of healing we are invited to participate in. The question remains as to whether we can hear God's words in our work. Good ethics consultation requires listening and helping others to hear, because there is oftentimes a desperate need for people to be heard. Patients, families, physicians, and nurses alike. In this way, through listening and attending, ethics consultation can be a work of God's love in the world. Next, we're going to hear from my colleague, Katie Wasson, who will be describing a clinical case for the panel to consider for discussion.
Mrs. Henderson is a 78-year-old woman who had a stroke. She was admitted to an outside hospital and was transferred to Loyola the next day. Before being transferred, she was intubated for airway protection. The possibility of surgical management of her CVA was initially discussed. She was found to have a large 7-centimeter right-sided ischemic stroke. When the patient arrived at Loyola, the neurosurgeon determined that surgery would not help. Currently, she is minimally responsive to pain, She's ventilated, and while partially breathing above the ventilator, she is otherwise non-communicative. The patient's husband is deceased. She has a son and a daughter. Her son, Peter, is an investment banker and lives in New York City. Her daughter, Patty, is an emergency room nurse and lives nearby. Prior to her recent stroke, Mrs. Henderson was a very active, independent individual who cared for her sister-in-law, who had had a stroke many years ago. Mrs. Henderson always said that she would not want to have things, quote-unquote, dragged out like that. The neurologist has said that surgery is not an option and that it would be several days before they could determine what would happen with Mrs. Henderson. The attending physician, Dr. Murphy, believes that it is clearly too soon to know if Mrs. Henderson will wake up or how severe the brain injury is. A family meeting was scheduled with both the daughter and the son present. During the meeting, Dr. Murphy asked for at least 5 days to continue treatment. Patty asked that all life-sustaining treatment be withdrawn immediately. Peter disagreed with Patty and agreed with Dr. Murphy's assessment of waiting a few days. Because the patient's children continued to disagree on treatment for their mother, Dr. Murphy called the ethics consult team. Now, during the consultation, the family tensions came to the foreground. Peter accuses Patty of being controlling and is thinking that she is a doctor. Patty accuses Peter of not being there for their mother and flying in at the last moment, expecting to call the shots, partially because he supports her financially. The ethics consultant tries to calm down the situation and focus the discussion on Mrs. Henderson and her condition. Now we're going to open the case up to the panel for comments, and Mark Kuczewski is going to facilitate our discussion.
And as we open this up for discussion, I just want to remind our viewers that you are welcome to send us questions or comments via email at ethicsconsult@lumc.edu, and also there is a phone line open for you to call us with comments or questions. So as we open this up, I want to ask my colleagues, okay, a case like this comes in, a fairly typical case, particularly at a tertiary care kind of facility. And our temptation is to jump right into the issues, but I always want to know, when you look at this case, where do you start? I mean, what's the process going to look like here?
Well, I mean, I think the first thing is to make sure you've got the facts right. So I think the first thing you do is go into the electronic medical record, make sure that the facts are correct, at least correctly conveyed to you. Oftentimes we get a consult request from a resident, from a nurse, from a social worker. So we want to make sure that the facts are essentially correct. And then once we've done that, then I think we can start our investigation with talking to the relevant stakeholders, healthcare professionals involved in the care of the patient, patient family members, and so forth. But I think first and foremost is making sure that those facts are correct.
Are there particular bases that you'd want to touch as you proceed here?
Sure. You'd always want to touch base with the person who initially called the consult. That could be a nurse, a physician, a resident, a chaplain, a social worker. In our institution, anyone is allowed to call an ethics consultation, although primarily it is the healthcare professionals that access it. You want to speak with all of those folks, particularly because there may be different versions or pieces of the story, and you want to be able to put those together as much as you can, as Kayhan was saying, get your facts, and also get the information and the perceptions of what the ethical issues are ahead of time.
You know, just to build on what you and Kayhan said, I would certainly agree with what was noted here, but one thing I would call attention to is the sense that the first thing I experience is a sense of dread when I get an ethics consult, and I wonder if that's worth our noting here, that for many of us, every time you get this call, it feels brand new. And we, in our conversations with each other, have often discussed how it can feel like the first time that you're doing this, even though you may have done it many times before. So for me, there's kind of an initial gut check of trying to get ready to engage in what I know might be a difficult process, and to try to calm myself down so that I'm ready to hear what needs to be said. And then just to build on what you had noted, Katie, as we're making those initial calls, one thing that I like to do is to try to listen as I'm speaking to perhaps the nurse who called the consult, and then I'm speaking with the attending, and then perhaps I'll have a conversation with the social worker. Are they telling the same story? Or am I noticing different interpretations of one narrative, even at this stage of the conversation?
All right, so it sounds pretty good. We calm ourselves down, put ourselves in the right frame of mind initially for it, go to the medical record and make sure that we understand the narrative of the case as it's conveyed to us through the record. Start to interview each of the principals and note their varying narratives and different perspectives on this. Do you typically have this culminate in a family meeting or a meeting among these parties, or who comes to that meeting? Where do you go from there?
We have 3 different levels, really. Sometimes it's a phone call, and you're able to deal with the question, the concern, the ethical issue through a phone call with the person registering that ethics consult. The second level would be to attend a family meeting, and that would mean that another service is actually running the consult, and it might be a palliative care consult or another medical service, and they're having a meeting with the family to talk about goals of care or whatever the particular issues are in the case. And so we might attend as the chaplain and the social worker and the nurses and the physicians would attend, as well as the family member. The third level is where we call it a full-blown ethics consult, and that means that we are actually the people who are organizing the consult. We are making sure that the relevant stakeholders are at the table, and we are the ones who are facilitating the ethics consultation itself once you get into that room. So for us, there are at least 3 different levels.
Okay, and when you get into that room then, what does that facilitation tend to look like?
Well, so, there's been different kinds of models described in the literature. There's like a pure facilitation model, authoritarian model, an ethics facilitation model. We're really striving for an ethics facilitation model, which means that we want to make sure that all the stakeholders come together and agree on some kind of ethically appropriate outcome, but not do it in a very heavy-handed way, so that we're not coming in as the moral expert. I think that's perhaps one of the potential barriers, and we can talk about that later when you and I are talking, is that one of the potential barriers of people calling an ethics consult is they view us as the ethics police or the moral authorities. And I think it's much better that we present ourselves and that they receive us as ethics facilitators, that we're really trying to make sure that everyone is being heard appropriately and that we're moving towards, there's a range of ethically appropriate options, and we're moving towards one of them, as opposed to doing it in a very kind of authoritarian way, or in a just kind of a purely facilitative approach where we say, well, whatever outcome we arrive at is appropriate. Well, no, that's not the case. There is going to be a certain range of ethically appropriate options. And so I think our obligation as ethics consultants is to kind of guide the conversation towards one of those ethically appropriate outcomes.
And are we usually able to get to something within that range or that people agree upon?
And, in my experience, we are quite often successful in doing that. I think that this is where we move more into art than science once you're in that room, because the context varies quite a bit, right? The question of who's really taking the lead in the meeting. I've consulted on ethics consultation cases where it's very clear when I come into the room that the attending plans on running that meeting. And then I very quickly have to adjust to say, how am I going to play a role in this conversation if the attending is more dominant in it? So that's the kind of thing that I want to attend to in a meeting. How am I being perceived? As I walk into that room, are people looking at me to lead it? Is someone else taking the lead? Another thing I try to attend to within the context of that meeting is making sure that communication is happening. So oftentimes an attending physician or a consulting physician will be relaying part of a medical history and give very medically oriented terminology in describing that case. I will oftentimes ask the question that I think a family member might be reluctant to ask to help clarify, to use more common language, to make sure that people are understanding what's happening. As we noted earlier, so much of what happens here is about good communication. So I think one of our roles in that context is to help people hear and talk to each other.
Thank you. I see we have an emailer here. The emailer asks us, these out-of-town relatives who arrive at the last minute cause us a lot of trouble. This is a fairly common scenario. Why do we need to take this son, Peter, seriously at all? I mean, in some sense, he's coming in, he maybe doesn't know what his mother thinks as well as the other daughter, and they're asking that, can't we simply ignore him and proceed with the daughter as the decision maker?
That's a good point, and sometimes it is a challenge because the information that we get might be more detailed from the son or daughter or relative who is closer geographically to the parent or the patient, and Mrs. Henderson in this case. But in Illinois, certainly, we actually have a list of surrogate decision makers in a legal setting, and it tells us who we need to talk to and in what order they take as far as who makes the decisions. And so for us in Illinois, and it may vary from state to state, the daughter and the son have equal decision-making authority and responsibility. It's both. Unless the mother had actually put that in writing and designated one of them to be her healthcare power of attorney. Ideally, we'd like them to be able to come to some agreement, and that's, as Kayhan was saying, as we're facilitating these very challenging and difficult cases, we want them to come to some agreement. We want to help facilitate ethically appropriate options. That's not always possible, but that's what we're trying to work toward. And if we can help them hear each other, as John is saying, and listen to each other and talk over these very difficult issues, we're going to provide support and guidance along the way.
And just to build on that, I mean, legally, right, both of them have the same amount of decision-making authority, and I would say ethically too. I mean, you can't just go to the person who's closest to the case, and oftentimes we see that in clinical cases. The team will defer to whoever is the most involved. And that's just a practical kind of response. They're going to talk to the daughter in this case. But the son has an equal level of decision-making authority, both legally because of the surrogate decision-making law that we have here in Illinois, but also ethically. And so I think as the ethics consultant who's involved in this case, we have to be attentive to that fact. We can't let, say, an overly aggressive family member kind of dominate the discussion, but we want to make sure that that other family member also has a seat at the table, is able to voice their opinion, and then also just give us a better sense of who the patient is, because I think that's really important.
So there's both good legal and moral reasons then for trying to include people, even people who are seemingly somewhat difficult to us in this situation.
Yes.
Good.
Absolutely.
Good. Okay, I see we have another email. Then this is a common kind of issue that's raised. In this kind of case, the emailer is telling us, look, you really have a conflict between two family members, and attending physicians can be fairly hard to get to meetings anyway. Do you actually need the attending physician to do this consult, or can you pretty much convene your meetings without the attending and resolve the issue?
So I would say that ideally I would have the attending physician in the room. In part because the attending physician has primary responsibility for this patient, and that I think it's also helpful for family members in this kind of instance to be able to get a reliable medical history on this patient. Oftentimes in these kinds of cases, in this a difficult stroke case, the family is going to want to hear from the doctor what the doctor thinks about what's happening. So that can be of great help. That said, have I consulted on cases in which we've been unable to have the attending present? Yes, and that does happen.
So there's not necessarily hard and fast rules in terms of we shut the consult down if we can't get the attending there, but how we proceed in the parties that we need in the room at the particular case. So sometimes the meeting happens with the attending, sometimes the attending's not there.
By and large, we would have the meeting with the attending, and if for some reason they chose not to or were unable to attend when everyone else could attend, so 10 people can make this particular time and the attending can't for some reason, that's extremely unfortunate. And I think, as John was saying, you really want that person in the room because they are primarily in charge of this patient's care, and there may be misunderstandings, misinterpretations, there may be changes in the medical condition even within a few hours. It doesn't mean that if that person can't be there, that everything gets shut down and you don't have the consultation. You might be able to speak to them by phone. You might be able to conference call them in. Certainly, as the consultant, you should speak to them ahead of time and find out what their particular views of the case are, even though you can't give the medical information. And you can at least relay that into the meeting. They might also be able to have one of their residents or someone else represent them and represent the medical team there if the attending can't be there. But that's certainly not ideal.
Just to build on that, I think it is essential to have the attending there. I mean, you want to get as many primary stakeholders involved as possible. So obviously the different surrogate decision makers, family members, physicians, nurses, social workers, other people that are involved in the care of this patient. So I think it's really important to get everyone's narrative involved. So then you have, I think, a complete picture. And then I think it's a matter of respect for the patient and for the surrogate so that they understand that this is an important kind of case, that the physician has taken time out. And the physician may have reported to us privately, look, I've already talked to this family, God knows how many times, and we can't seem to make any progress here. And I've had a case recently where the physician just said, refused to be involved in the case. And I think that's unfortunate. I think it's really essential to have, I think, a proper consultation, to have that attending involved as a sign of respect, and also just to make sure, like as John said, that person's ultimately responsible for the care of this patient. And so to have a family meeting, especially an ethics consultation family meeting without that physician there, I think you can have a big gap in trying to resolve the issue.
And on the flip side of this is that I think that the nature of this work is that it requires some adaptability. And here's an opportunity where, let's say we can't get the attending, I can still learn an awful lot about this family in this meeting, right? And I can get a better sense of where the friction points are between these two siblings, have a sense of what their history is with their mother. Do they have shared agreement on what mom would have wanted, but now they're disagreeing about what they should do now? Or do they have different feelings about what mom would want? There's still work that can get done. And I think that one of the things that characterizes our work in ethics consultation is this need to adapt to fluid circumstances, because hospitals oftentimes offer us that.
Thank you. Let's sort of play the case forward a little bit. You get the two family members together, and they come to more or less an agreement that, in fact, yes, the patient probably would have wanted to stop aggressive life-sustaining treatment at this point. And now we get the attending together with them, and the attending's still pushing for his 5 days. And where do we go with that? I mean, that's a pretty classic ethics consults. Somebody's saying go and somebody's saying no. And what do we bring into that room that helps us try to get them to that consensus we talked about?
That's a challenge. It goes back to John's earlier notion of that feeling of dread. I think that's a challenge because what I was going to mention earlier, and I think it's tied to what you're asking, Mark, now, is that I think that feeling of dread comes to, what can we really do to help move this case forward? Because we don't know the family. We don't know the team very well. I mean, we're really outsiders. And so really, what can we do that's any different than just a typical family meeting where the physician's gone through the litany of medical facts and maybe talking about a prognosis, maybe not? What can we really do to really push that discussion forward? I think because we're doing this in a very purposeful and hopefully transparent way, so we're not just having another family meeting. We're really talking about often goals of care. Right. Sometimes that's not even put on the table. And I'll say, well, what are the goals of care for this patient? And what are the benefits and burdens? I mean, I had a case with one of our colleagues, and he said, I'm going to write that down. I've never heard that before. I've never heard of benefits and burdens. And I said, well, that's a good way to kind of orient yourself to the moral dimension, and even beyond the moral, just on a very practical level. I mean, our colleagues are very practical people, looking at the benefits and burdens. And so I think, going back to your original question, it's about go or not. I think when we put it in those terms, and it goes to the heart of the ERDs, what are the benefits and burdens? Once that's spelled out in a very direct way to the team and to the family members, then oftentimes we'll see some real progress made, I think, with a given counsel case. And I don't know, it's interesting to see how it often will unfold typically in a positive way. Once we've had those discussions, goals of care, benefits of burdens, I think just putting those two things out on the table, we sometimes will get through whatever impasse we've encountered.
Yeah. I mean, if I were to pick up on your question, Mark, what would jump to my mind would be some relief that I have two family members who were feuding and now are on the same page. And now I really want to hear from that doctor, and I want these children to hear, what does that doctor think he or she's going to learn in 5 days? What's that going to yield for us? And then I want, once the family members have heard that, I want to ask them about how that sounds in terms of burdens and benefits, right? Perhaps it's the case that in this kind of instance, we could argue for a limited time trial, that these children would say, 5 days makes sense now that the doctor has told me that this is what's happening. Or I might find myself in the position where I'm trying to gently say to the physician, based on what you've just described, you might learn in 5 days. And based on where we are in this case, and thinking about Directives 56 and 57 on ordinary and extraordinary care, we might need to listen more carefully to this family. And then it might become a conversation with that doctor about, do you think it would be immoral if we were to be in a position where we were talking about withdrawal of life-sustaining technology at this stage of the game? And here I think we're in that realm of prudential judgment based on a fuller picture of the medical facts offered by the physician, a sense from the surrogates of what their mother would have wanted, and where those two can come together.